Hello, and welcome to Essentials of Hospital at Home Pharmacy, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. The Hospital at Home Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website. Be sure to check out our TA Center for helpful hospital at home program resources and tools, as well as our recently refreshed Research Center. Follow us on Twitter and X. This is webinar 31, so you can view any of the 30 user group webinars that we've run in the past on our website. You can find a topic you've been thinking about or perhaps working on and take a look. There are lots of resources there. It's now my pleasure to introduce our moderator for today's webinar, Dr. Pamela Sanger. Dr. Sanger is a senior medical director at Inbound Health. She has practiced clinically in the hospital home model since 2017, including at Mount Sinai Hospital in New York City and at Yale New Haven Health in Connecticut. She's co-authored several hospital home related peer-reviewed publications. She's completed her MD, MPH and internship and residency in internal medicine at the Icahn School of Medicine at Mount Sinai, and we're very pleased to have Pamela Sanger take it away.
Thank you so much, John. I'm very excited to be here today and to introduce our panel of experts. Again, the title of the webinar is The Essentials of Hospital at Home Pharmacy, and we have an esteemed panel of 4 hospital at home pharmacy experts. With us, we have Adam Amenyador. He's a manager at Chartis, aligned with the digital and technology transformation business line. Before joining Chartis, Adam was the lead hospital at home pharmacist at Yale New Haven Health System, where he helped develop the HA program. Catherine DeSanctis is the director of pharmacy for the HA service at Mass General Brigham Healthcare at Home. She has oversight of pharmacy initiatives for home hospital services and serves as a liaison between clinical and operational leadership for home hospital and pharmacy leadership across all facilities. Maggie Pinovich is pharmacy manager for critical access pharmacy services in the Northwest Wisconsin region of Mayo Clinic Health System, and additionally serves as pharmacy subject matter expert for Medically Home, helping organizations across the U.S. develop pharmacy services for their hospital at home programs. Kayla Popova is currently the pharmacy manager over central pharmacy distribution at the University of Michigan Health, Michigan Medicine. And prior to that was the clinical pharmacist specialist for their hospital care at home program. She graduated from the University of Michigan College of Pharmacy and completed her pharmacy practice residency at the University of Minnesota Medical Center. Next slide. None of our panelists have any conflicts of interest to disclose. And now each panelist is going to provide a brief orientation to their HA program before we get into the meat of our webinar. So we're going to turn it over first to Adam Amenyador.
Hello, everybody. Excited to be here. So I practiced at Yale New Haven Hospital. That's where the hospital at home program was. And our program launched at New Haven, Connecticut in June 2022. Our inpatients were admitted within a 25-mile radius of each hospital. And we actually drew our patients from 4 different hospitals within our network. And up to this day, we had served over about 1,500 patients overall.
Hi, everybody. Thank you for the opportunity to be a part of today's session. I'm looking forward to sharing our experiences and learning from my co-panelists today. So Mass General Brigham Home Hospital, it's a unified service line across our health system. We have 5 acute care hospitals that serve as our brick and mortar sites. We currently have capacity for 70 beds that serve patients in the greater Boston region. And we support close to 6,000 admissions and have saved more than 25,000 facility bed days since January of 2022.
All right. Hello, everybody. I'm excited to be here today. I love hospital at home and this mission we're on to provide good patient care. So for Mayo Clinic, we started our program back in July of 2020, and it started in Florida and then spread to Eau Claire in Wisconsin in August of 2020. And after that, we moved to Phoenix in Arizona. So we admit patients with a 35-mile radius of each of our Mayo Clinic campuses. So it's 3 different hospitals covering 3 different states. And we've got 1 command center that serves all 3 states across 3 different time zones. Specifically in Eau Claire. So before I joined Medically Home, I was the operations manager at Eau Claire and helped develop the pharmacy services for our advanced care at home program there. We're a community-based hospital, so a little bit different than Arizona and Florida that are academic institutions, and we serve a very rural population. And so far, advanced care at home, our program has served 5,000 patients and saved over 20,000 bed days enterprise-wide. So I'll move on to Kayla.
Thank you, Maggie. Very excited to be here as well. So for the University of Michigan Health, we originally launched our program in 2020, but we revamped it with the new launch of February in 2024. We derive our patients from one academic medical center, and similar to we serve inpatients within a 25-mile radius of the hospital. Since we relaunched, we've had 490 admissions with an average length of stay of 3.9 days. We've had a total of 1,890 patient days and a peak census of 11 patients. Our program does have a dedicated clinical pharmacist, and so far, inpatient pharmacy has dispensed over 35,000 doses since we relaunched in February.
Thank you all for those introductions. So in order to make the most of our time together today, we're going to do a rapid fire of different topics in order to cover what we think are the most common questions we hear about hospital at home pharmacy. The plan is to pose each question to 1 or 2 of our pharmacy experts, but the others, please feel free to jump in, chime in if you have something to add. We would like this to be a discussion as much as possible. So I think we can go to take the slide down. Great. And we can all be available to jump in. So our first question, I'm going to direct towards Maggie and Adam, and this is the ever-pressing question of staffing. So let's talk about, should a hospital at home program have a dedicated pharmacist? Should they have it from day one? How do you justify the cost? And is there a patient census at which it becomes necessary? Tell us about your experience and what you think about this question.
I'll go first and then I'll pass it over to Adam. So of course I'm biased because I'm a pharmacist, but I really feel strongly that a hospital at home program should have a pharmacist dedicated to the service from the start. Ideally, they'd be in the command center, but somebody on the service at a minimum to help with the program is ideal. Just like if you're opening a new unit in a hospital, we push for a pharmacist to be part of that decentral unit. Same goes for home hospital. You want a pharmacist embedded. And the way you can justify cost is we're doing a lot of work with medication coordination, optimizing dosage forms, timing in the multidisciplinary rounds. So if you've got a pharmacist dedicated, you're going to avoid courier costs for additional runs of medications out to the home. You avoid some provider or nurse visits to administer medications. There's a lot that pharmacists can do. And then we can do IV to PO, so shorten length of stay, get the patient discharged, help coordinate their discharge and get meds to them on discharge. So I think it's pretty easy to justify a cost. And I also want to put a plug in for, in addition to a pharmacist, it's great to get technician help too. It's a lot of manual dispensing from the pharmacy and work that has to be done. So you can't forget about technician support in addition to the pharmacist. So when I put together kind of at a census of when should you add a pharmacist, I have a pharmacist from the start and a technician supporting the hospital if that's who's doing your dispensing. And then as you get closer to your census of 8, adding weekend help through pharmacist and technician, and then a census of 20, adding another pharmacist, and you can kind of like go on from there. But Adam, what do you want to add?
Wow, I think you hit every nail. So I also want to add that I am very biased in this with this question. So in my role, I served as the dedicated pharmacist for the program. So I am in favor of having the dedicated pharmacist on board. So not only from being available to round daily with the team, like Maggie said, it's beneficial because you're able to identify opportunities to optimize therapy, which directly affects length of stay, and length of stay affects costs. So right then and there, you are saving money by having a pharmacist on board. Also, I came to find that having a pharmacist on board directly affects provider experience. And I'm lucky enough to have the provider I worked with as our moderator, and she can speak more onto it.
You preempted me. I was going to say, yes, I directly benefited from that. And I feel like we were sort of almost a dyad working very closely together.
Correct.
Mhm.
So that provider experience definitely increases efficiency. And also, if you think about it in a grand scale, it's going to minimize turnover because you want your provider happy at what they're doing. So you don't want to have to spend money and having to replace your provider. And outside of provider efficiency and also provider experience, the patient experience, also having a readily available pharmacist there to answer all these questions that they might have in this very unique experience that they're having is a very plus for the patient. So they feel more comfortable if they have to come back into the program. So that and also increases your patient census in the future. So I think having a pharmacist on board is definitely a plus.
Yeah, and I will just also add, as a provider who's provided care in this model, it is a unique way of providing care, and there are some changes to medications and changes to care plans that are unique to this service, and having the access to a pharmacist who's available to answer those questions in a timely manner and understands the model is definitely beneficial. I did want to ask a follow-up of both of you, or Catherine and Kayla, feel free to jump in, but even if you have a dedicated pharmacist, is there an ideal way to handle after-hours pharmacy help? How would you approach
The way we've generally done it is the inpatient pharmacy, and that we treat it a lot like our critical access hospitals, which we're allowed to do in Wisconsin. I know that's not the same across states, but the inpatient pharmacy is available 24/7. They've got access to the AHR. They can dispense meds. They're familiar with this acuity patient level. So for that reason, we leverage our inpatient pharmacy to provide that around the clock coverage. So just like kind of in the brick and mortar, once the decentral or the pharmacist leaves for the day, sort of everything moves to central pharmacy.
Correct. Yeah, it's the same way we handled our process too. So the decentralized pharmacists, the dedicated pharmacists will work from the day shift, we'll say from 7 to 3, 4 o'clock. And then just like how it is in the brick and mortar, you have an evening pharmacist that takes care of other units, including the hospital at home.
And we do it similarly at Michigan Medicine as well. We'll have the inpatient pharmacy team take over the dispensing process, and then we have a clinical pharmacist that signs into the treatment team should there be clinical questions in the evening or morning.
Similar model here. I think the overarching principle that it sounds like we share is these are acute care patients, so we want to make sure that they have the same level of pharmacy services that they would just like as if they were in the brick and mortar. So the same applies for our program as well.
Great, thank you. So on to question 2, and this question is primarily for Catherine and Maggie. Could you give us a brief, as brief as you can, overview of your respective dispense models? So centralized versus decentralized, meds to beds versus delivery. Do you have a hospital at home command center cabinet? And how do you handle cart fill?
Sure. Go ahead, Maggie.
Are you sure?
Yes.
Okay. So we leverage our electronic health records. We use Epic for Mayo. So moving from admission to discharge, and I think we get into this a little bit later, but we do leverage automation. So our process looks a little bit different on admission to discharge. So we're looking at if they're reduced length of stay, looking at their active orders and any new orders, and we transcribe those orders into our MediCue portal, which then flows into our automated cabinet. And then if it's a new admission, we looked at sign and held orders and we verify them in the sign and held state, and we transcribe those orders into our MediCue portal. We fill a couple of cubes, which I'll talk to later, and those orders then release when the patient moves into their virtual hospital bed. We have our medications prepped and ready to go with our paramedic, who's generally responsible for admission. So we tend to have that ready, and the paramedic leaves from our campus, which makes that feasible. And then as we go through the hospital stay on discharge, we process those discharge prescriptions. We fill those at our on-campus outpatient pharmacy, and then we deliver those to the home so that they have the medications they need on discharge. So we're kind of doing the traditional admission, but filling that automation, sending it out to the home of the patient, taking care of ongoing needs through couriering meds out or activating meds that are in that automation, and then meds to beds on discharge.
Yeah, so a couple key differences, which is, I think, a really cool opportunity to showcase different ways to do this. So I mentioned at the program overview at the top that we have 5 acute care hospitals for MGB Home Hospital. So our pharmacy model relies on those 5 inpatient pharmacies within those 5 facilities. So in that sense, we're pretty decentralized. We don't really have a central pharmacy command center for medication needs. We also don't have any automated dispensing cabinets, and I'll talk a little bit later today about how we manage meds in the home. We don't use something like Medicube. So really all of our meds come directly from inpatient pharmacies, the exception being a small supply coming out of our MIH paramedic trucks. So starting from the admission, our admitters also do that sign-in health workflow that Maggie mentioned. And they do that to avoid inadvertent med administration while the patients are still in the brick and mortar setting. And because they're signed and held, those med orders don't currently flow to a standard verification queue for pharmacists. So we've built out a report for pharmacists to run to help identify those orders, verify them, and initiate that dispense. And then we have a second report to identify meds that are going to be continued on the admission or transfer, and then the pharmacist manually dispense based off of that report as well. As you can imagine, that's a pretty manual process, can be open to human mistakes, and it's one that we're really excited to optimize in the spring with a new verification queue that captures those signed and held orders. But after their orders are dispensed and packaged for admission, we typically do a patient bedside delivery so that we can guarantee those meds are available at the admission visit. And that's when our field teams will prep the medications for the patient and really do some hands-on education for how med management is going to look for the duration of the service. And then finally, I'll end just to touch a little bit about cart fill. I could go on and on about cart fill. We have a 24-hour cart fill model for our routine doses each evening out of each pharmacy. And we have found that to be a really nice balance between effective workload for dispense with the risk of wasting given the long lead time with a 24-hour cart fill.
Thanks, guys. I have a question about that the cart fill. So you 24 hours. So what does that mean operationally? When are the meds going out?
Yeah, happy to expand on that, Pam. So for us, and I'm sure every team is maybe a little different, but at MGB, a 24-hour cart fill really looks like this. So if today is day 0, in the evening, the batch will run and it'll capture doses that are due starting at 11 a.m. on day 1, so tomorrow, all the way through 11 a.m. on day 2, so the day after tomorrow. Those meds are dispensed. They'll be dispensed, for example, this evening. They'll be prepped, packaged in the appropriate containers, and then set up for a courier pickup early in the morning. And we do that to try to avoid any disruptions, late night deliveries to a patient's home, and try to respect their well-being as well.
Great, thank you. So moving right along, question 3. Anyone using, well, this question is directly for Maggie, but anyone else feel free to jump in. Who's using lock boxes or Medicubes? Has this had a positive impact on med waste? And are there any operational challenges related to cost, keeping track of inventory, or operator issues?
Yeah. So we have used Medicube at our Eau Claire campus for over 3 years now. So if you're not familiar with them, they're automated cubes, and they were designed for patients to use in their home for at-home administration of medication. But the reason we selected them is because there's an online portal that you can automatically update doses, change doses, activate meds. So it was the closest thing we found to like a Pyxis or Omnicell machine. And so we really wanted to try that because we started out with our long-term care pharmacy and then our hospital pharmacy supporting and just getting couriers out to the home, getting meds out there as needed, changing meds. There's a lot of logistics that go into it. So we found a lot of benefit. We've had minimal waste. So we use 2 cubes per patient. We have a general cube, which houses our most highly used oral medications. And then we fill a patient-specific cube that's based on their specific orders for the admission. The patient-specific one we fill with a 7-day supply, and then we waste whatever is not used. And these are oral generic tablets that are minimal cost, so minimal waste and cost associated with that. the generic cube or the general cube, we treat like automation, so we reuse the supply in that, and so minimal waste with that as well. The biggest challenge has been the lack of interface, and so there's the ability to interface, but we don't have an interface, so the pharmacist has to transcribe all of the orders from the EHR into the portal for Medicube. And so that puts you at risk for error, obviously. So as dose changes happen, you verify that order in the EHR, and then you put that in the portal, and that flows through to the portal. But the advantage is if you as a provider want, a potassium dose now or a Lasix dose now, I verify that order, I put it in the portal, and that spits out to the patient 2 minutes later. And so that's immediate access to a medication versus what we promise a lot is 2-hour turnaround time, right? For us to process that in central pharmacy, get that ready and courier that out to the home. So there's that added benefit. So we minimize courier runs. So the cost up front is expensive. It's between $1,000 to $2,000 per cube, but we've had the same cubes for over 30 or for over 3 years. So the cost is made up for itself with reduced courier costs. And then we do have a technician, which I mentioned before, that we need that fills that cube. The general cubes we just fill in downtime, the patient specific on admission. And we keep a separate inventory for that because they're not unit dose tabs and caps in that. They come out of bulk bottles. So we actually partner with our outpatient pharmacy on that, ordered in our most common meds, and anything that's going to outdate, we return to the outpatient pharmacy to put in their carousel for dispensing or for use. So we have minimal waste associated with that. But I guess it serves as a lockbox too. You have, you can see the inventory, it captures all the dispenses, it just gives you insight into what's happening in the home for everything. So are there other questions related to that, or did I cover everything?
I think you covered everything. I guess I would ask the other panelists, for those of you who have not implemented this, is this something that you're considering? What, has there been discussion? What would be a reason not to go in that direction?
Yeah, so I think I can answer this. I think at the University of Michigan, we've assessed it, but there's been some concern with the upfront cost and then the cost of manpower to maintain it. So like when we get the cube back, medications that are in there, there's also concerns too, just about medications going into the patient's home and ensuring compliance with temperature and how exactly that was stored, which the cube will help with, but that's something we would want to kind of vet out a little bit further as well.
We're intrigued by this and obviously see the significant benefits by it. So we're considering maybe piloting with types of medications rather than, kind of going full steam ahead, just to assess some of those concerns that Kayla mentioned and try to build a better business case to really, roll it out in an expansive way.
Great, thanks guys. Moving right along, question 4 is primarily for Kayla. Can you tell us if your clinicians are using a first and urgent formulary carried by a field paramedic or nurse? How extensive is that formulary? How do you stock it? Any challenges with that model?
Yeah, so at Michigan Medicine, we do have a mobile integrated health or MIH formulary that our in-home clinicians do carry, and it's for our dedicated in-home clinicians. It does have quite a few medications. It has over 50. It has medications like that you might need for anaphylaxis, like epinephrine, IV Benadryl, IV methylprednisolone. It has some antihypertensive agents, some agents for pain that you might need, like ketorolac, IV diuretics, antiemetics, electrolyte supplementation. It has fluid boluses. So it does have a lot of stuff, which can be very helpful. I think another very helpful aspect of it are the antibiotics that we have. So we have cefazolin, cefepime, ceftriaxone, vancomycin, and we've tried to kind of leverage it for patients that might be admitted midday. And then can we use it, the MIH formulary, for their evening dose of their antibiotic, and so then we can save a paramedic visit that way. Or it's been very helpful for our congestive heart failure patients that are receiving IV diuresis. Their labs just came back, point of care labs, and their magnesium is low. And we want to quickly supplement them with IV magnesium. So it's been very helpful in those cases where we don't need to then have a courier come to the inpatient pharmacy to pick up this medication that could then take potentially 2 hours to get to the patient's house, pending when the courier can come and pick it up. Other things that might be more beneficial too is that if a patient's decompensating at home and our paramedic is there, we have these emergency medications readily available. Some challenges are the quantities that are stocked on each truck and the doses available. So for instance, say we have a paramedic that's going to patient A's house at 8 in the morning, then at 10 in the morning, they're going to patient B's house. Patient A needed to use the IV magnesium. Well, we discovered patient B also needs to get IV magnesium. And we only have one IV piggyback of magnesium stocked on the truck. So that would be a challenge. Another thing is that because it is a pretty extensive formulary, there is always the risk of expiration. So it's kind of balancing how many medications do you want on your formulary against the cost of that medications potentially expiring out. But I think overall we've really enjoyed it, and it is stocked by our paramedic partners.
Thank you, Kayla. I can speak as a clinician who worked in a model with this option that was, incredibly helpful for patients who might be decompensating. Patient, if a med happened to be missing, couldn't be located in the home, kind of innumerable instances where that definitely came in handy. Yeah. Next question is for Adam. Can you tell us, how did you handle PRNs? How do you decide how many to send out? Do you set an anticipatory supply? Do you fill them in real time? Do you use urgent couriers? And given that couriering all doses of PRNs is obviously going to be cost prohibitive, how much wasted PRNs is acceptable, do you think?
Oh yeah. So first I want to say we, like Catherine, did a 24-hour cart fill model. So all our medications for each patient were picked up at 2 p.m. for the patients, and it's supposed to serve as a 24-hour supply for the patient. For PRNs, the way we handled it is for our initial admissions. So this is admit day 0. Each patient is given a 24-hour supply of that PRN. And sometimes we've decided to go with 48 hours supply of that PRN. And we don't dispense these PRNs daily unless patients are using it. And the way we track the use of these medications is through a report that is ran on a daily basis. So it was part of my responsibility to come in and run a report every day at 12 o'clock to see what had been used the day prior, to see what I needed to replace with the upcoming cart fill. So that's how we were able to stay ahead of what patients need. And this way we also minimize just sending unnecessary dose and waste.
Thank you.
You're on mute.
I think you're on mute.
Thanks, guys. Question 6 is for Catherine and Kayla. We're going to get into the meaty topic of controlled meds. So are you filling them outpatient pharmacy, inpatient pharmacy? How are they ordered? Do they transfer to the inpatient MAR? If you're using an inpatient MAR, do you have a different process for filling controlled meds after hours compared to within hours? And are you able to provide IV controlled meds at this time?
Yeah, I can start. So I think I mentioned in my previous response about our overall model is we are an inpatient, we are supplied by inpatient pharmacies. And so the same stands for our controlled substances. And the foundational principle of we manage these patients as best as we can, just like we would in the brick and mortar, still applies. So overnight, regardless of the time, if there's a need, we're following the similar process. So for us, like I said, while they're processed by our inpatient pharmacies, we do follow a hybrid inpatient-outpatient model. We have an inpatient order that supports your standard clinical workflows, order entry, how to, monitoring the patient. It supports MAR administrations. But we also have a matching outpatient order that the pharmacy dispenses against, and that helps mitigate liability, transfers chain of custody to the patient. We dispense a 24-hour supply, just like we do for our non-controlled meds. And in order for the pharmacies to dispense against that outpatient order, we installed outpatient dispensing software within NARC vaults for each of our pharmacies, and effectively process the medications that way. So after we order the meds and dispense them, they're packaged in serialized tamper-evident bags. And then they follow the same courier transportation process. We have a signature upon delivery, but we really take care to not highlight to anybody that there's something special that's in this bag. There's no auxiliary label on the outside package. There's no indicator on the pickup log that this is different. There's really no variation. So nobody should really know other than, probably the pharmacist or tech who did that dispense. Once in the home, any activities with a controlled substance are witnessed by a virtual nurse. That can include a daily inventory count, all administrations, including self-administration, waste, and that's completed in a non-retrievable waste container that's provided by our team. And then our virtual nurses document that serial number on the tamper-evident bag each time. And that's kind of how we monitor, for any potential diversion. We currently only do this for non-IVs, but we're looking forward to focusing efforts on expanding this to IVs. We really anticipate following a similar foundational process. The biggest key difference is we're not going to have patients self-administer IV controlled substances. And so they're not going to have to access it. It's really only going to be limited to our clinicians. So we can use something a little bit more stringent with control, like a lockable container, rather than these kind of tamper-evident bags. But the key foundational principles should still remain.
Yeah, at Michigan Medicine, we do have a similar process to what Catherine described. So our controlled substances are largely filled here by our outpatient pharmacy that's associated with our academic medical center. We send a 72-hour supply with each outpatient prescription, but since the hours of the outpatient pharmacy can be limited, we do allow for an urgent dispense process from our inpatient pharmacy. And so that will typically be reserved for like acute needs. So if the patient isn't able to bridge with their own supply on admission until the outpatient pharmacy opens the next day, our providers can request this urgent dispense of a controlled substance from our inpatient pharmacy. And so again, our inpatient pharmacy is going to fill that based on an outpatient prescription, and we're going to do the 72-hour supply like the outpatient pharmacy would do. Since the outpatient pharmacy shares the same address as our inpatient pharmacy, we have the same DEA number, so that's how we're able to do that. Because these medications are filled on an outpatient prescription, they are considered patient-owned med regardless. So we have the orders specifically built within our order set that it'll be a linked inpatient order plus an outpatient prescription. And so that inpatient order, like Catherine said, is for MAR charting purposes, everything that you would need from the Epic perspective. And then the outpatient order is for that prescription fill. And as far as IV controlled substances go, we are working with our in-home clinician partners to try to provide IV controlled substances, but that's going to require separate DEA licenses and a different process. But we are trying to work on doing something like that where they'll carry that on their truck.
Great, thanks, guys. So you mentioned patients on meds. So our next question is actually all about that. And this is for Adam. What do you do when a patient's on a chronic med they've been taking for years? They're used to it. They know any side effects or issues they might have with it, and it's not on the hospital formulary. Do you switch them to a med they've never taken, maybe never tried before that's formulary? How much are you trying to keep them on their home chronic medications? When is it appropriate or inappropriate? And any advantages or disadvantages to doing patients on meds?
Yeah, so this has been a topic that we're still trying to figure out what the best process is. But as an institution, we felt like the best thing to do was to try to be consistent. So you want to be consistent with what your institution's protocol is when it comes to patient-owned meds administration in the brick and mortar. So generally, we don't approve medications that we have formulary alternatives to. So I understand they might be using a medication that they've had chronically, but if we have an alternative, and this is for safety and also legal reasons, you want to use medications that are being supplied by the hospital. Just in case anything goes wrong, we know where that medication came from, how it was stored, and also just the side effects that might be associated with said medications. So yeah, it's our job as the pharmacist to then speak with the patient to get them to understand. And that is something that is very necessary. And you will come to realize once you're able to have that conversation with the patient and explain to them the reason why, they're usually more amenable to using the formulary alternative unless they have some set allergy to it. And that is when you would go ahead and use their patient medication. So like with that one, there are exceptions. Some exceptions to us using patients' own med supply is that we tend to have patients administer their own medications. And this is non-IV. Let me be specific with that. So certain medications like inhalers and insulin, the biggest thing for those type of medications are the ease of use and also the safety. So with hospital at home being a wonderful program as it is, we want the patients to be able to be comfortable taking their medications. So for inhalers, there are different types of inhalers. And as all pharmacists will know, it can be tricky when you're using certain inhalers that you're not comfortable with. So in those situations, we would approve a patient's own inhaler. So it's number one, ease of use. And we know that the patient is receiving the right amount of drug that they're supposed to be using because they know how to use that medication. Second, being an insulin. So whenever a patient has an insulin pen, for our formulary, we don't carry insulin pens. So for a patient to be on insulin, they will have to be on the insulin vials. And for safety reasons, you have to have a nurse available to administer those insulin subcutaneously. So if a patient has a pen and it'll be easier for them to use, and we also know it's safe, we will then switch to their patient-owned med for them to use those medications. So all this is to say is there are gray areas to patient-owned med usage, but the most important thing is trying to be consistent with your protocol for the brick and mortar, so there aren't any deviations that could lead to any safety or legal issues.
Thank you, Adam. That was very detailed. Appreciate that response. Let's see. Another meaty topic is antibiotic dosing, and this is primarily for Catherine and Maggie. Are you leveraging IV push for all antibiotics that can be given that way? Why or why not? Are you using pumps and continuous infusion for antibiotics that require TID or more frequent dosing? And are there any antibiotics that you just have not been able to accommodate at home?
Yeah, I can kick us off. Agreed. It's a big topic. So the answer is yes. So our strategy optimizes use of, like you said, IV push as much as possible, premixes, vial to bag adapters, mini bag pluses, just to minimize the need for any kind of manipulation and pharmacy compounding as much as possible. We do also use 24-hour infusions for certain antibiotics when it's clinically appropriate. Those do typically require compounding just because of the size of the bag and that's not typically available on the market. Our admitting teams are equipped with a really nice conversion chart to help guide their screening and get them, prompt them to think about, if the patient's on this particular regimen in the brick and mortar, here's the common conversion for something that might be more friendly for the patient in the home. So the most straightforward example is your Q6 intermittent Zosyn. That's a usually pretty straightforward 24-hour infusion that we can convert. Another one that we often see is Unison, another antibiotic with Q6 dosing that can sometimes be a barrier in the home with a lot of interruptions to the patient. So here we might want to think about like ceftriaxone IV with metronidazole to help provide the right coverage. So we've been able to accommodate most of our antibiotics through some sort of conversion and those kinds of tips and tricks. There are some antimicrobials. We've acyclovir, AHCaH. They require compounding. They don't have any good, other options, and they have limited stability data that doesn't help support some of that compounding. We accommodate them on a case-by-case basis, but it really requires a lot of enhanced coordination with the pharmacy team and the field team to make sure that we're timing everything out appropriately. Dapto actually used to be a pretty hard exclusion for us as well, but we've recently been able to reliably provide that now that we compound them in the IV room for our patients and get them to the patients' homes. And then in terms of pumps, we do utilize CAD pumps to support safe IV administration. We have a new IV pump team, just as we would for a brick and mortar. And in the past, our pump library strategy was kind of limited to like home hospital meds only. But as we've grown, we're shifting to a much more like prospective approach to build out a library that resembles more of a med surg floor, with the nuances of home hospital needs, like a 24-hour infusion included in that.
That was incredibly thorough, and I don't have a ton to add. We follow essentially the same here at Mayo. So we are leveraging IV push as much as possible up to the Q8-hour dosing. For the meds that are Q6 hours, we do a 24-hour infusion via the CAD pump. We had CAD pumps on campus because we have a home infusion pharmacy as well. So we were able to leverage some of their knowledge to help us, but our inpatient pharmacy team does compound for CAD pumps after hours. So we do carry that between into our inpatient team for compounding. And we also have started continuous infusions via the CAD pump for fluids. So like 24-hour fluids, that's been helpful, and the nurses prepare that and start that via CAD pump at home. That's been an improvement for us. We used to have pharmacy prep that and remove the air from the bag, and that's a lot for an inpatient tech to stop what they're doing in the evening and middle of the night to get that ready to go out to the home. So this is a huge deal, and the 24-hour antibiotics, if you can do that, are a game changer, I think, for your visits in the home, the number of visits you have to make, and just timing of visits. It'll help you scale. And so it really is, it might be a shift for your inpatient team to compound that or do that, but it's really important for your hospital at home program to sort of bite the bullet and take on that operational challenge.
Awesome. Thanks, guys. I think we're heading into our last question. And I know this, I think I already saw this come through the Q&A. So there's a lot of questions coming through the Q&A. I don't know that we're going to get to all of them. Here's one before we're moving on to the next section. And this is primarily for Catherine. We talk about barcode scanning meds as the ultimate in terms of patient safety and aligning with brick and mortar practice. I understand you're doing this in your system. And what does it take to implement, and what challenges might arise after implementation?
Yeah, so happy to share my experience. To start off, we're an Epic institution, and as such, we can leverage their mobile platform. It's called Rover, and it facilitates barcode med administration in the home. But before we could really effectively utilize it, we had to take a step back and think about how we're storing meds in the home. Prior to implementing BCMA, our field clinicians would set up pill boxes for patients. They would set up a pill box for 24 hours worth of meds in the home. And what that meant was that the meds were being removed from their unit dose barcoded package. So that means even if we have this really nice fancy phone that can do barcode scanning, we're not actually going to barcode scan because there's not going to be a barcode. So even though we recognize that pill boxes are super useful in this unique setting, where we can like really get a peek into how patients really are adherent to their meds, they come with their own challenges, especially if you think about how in acute care, med regimens change really, really frequently. And so that they can pose their own safety challenges. So we fundamentally shifted to like a true inpatient pharmacy med use process in order for BCMA to work. So now all of our meds remain in the unit dose package up until med administration is going to occur. And they're set up in different cases to help support patient self-administration in a safe way, while segregating medications that we don't expect that they're going to need while they're in the home on their own. So basically, like I said, those phones are equipped with the Rover app, and the camera acts as a barcode and as a scanner, where they can scan the barcode, and that will automatically populate the MAR just like it would in the brick and mortar. And over the past 6 months, I took a peek this week, and our compliance rate is now at 82%, which I think really speaks to the success of the way we've set it up. And those 18% of doses, the majority of them are not scanned because they're those self-administration doses. So maybe it's like your bedtime dose or something like that. I think I wouldn't call it a challenge. It's just trying to be cognizant and mindful of how to balance and respect the benefit of patients kind of being independent and being able to independently manage their meds and be adherent. So we haven't really moved in the direction of we want to witness 100% of doses. So we haven't gotten that BCMA up to 100%. So it's just really thinking about how do you want to fundamentally approach that, is it necessary to get to 100% BCMA if we can trust that our patients are used to taking their nighttime statin, for example. So that's been our story thus far, and I think we've seen a lot of really good success with it.
Great, thank you for that. We're going to move into the next segment of our webinar, and we've asked each of you to consider and think across your experience. Has there been an aha moment that has come up during your period working with hospital at home? And also, what has been your biggest pain point? So we'll go around Adam, Catherine, Maggie, and Kayla in that order. If you could tell us your aha moment, your sort of light bulb moment, and your pain point.
Sure. I think my aha moment is something that's already been discussed a little bit, which is the 24-hour infusion medications. I think once we're able to incorporate that, it kind of opened up the floodgates for the type of patients that we could bring in. Because before that, we were limited. So once we were able to incorporate that, we were able to increase our census. And that leads to another aha moment I just want to quickly talk about, which is a safety issue that we were able to mitigate. So by having these specific hospital at home medications directly just for our patients, when patients end up being sent back to the brick and mortar, the issue is now that the brick and mortar still has those orders on the patient MAR. And sometimes the patient misses a dose because they don't supply that in the brick and mortar. So we were able to work with IT to kind of develop a consult service where a pharmacist was automatically consulted immediately when the patient was sent back to the brick and mortar, and only if the patient had specific hospital at home medication. So we were able to mitigate any safety concerns with that. Now my pain moment, I think we probably all shared this. There was a lot of, not a lot, but we used to have a lot of medications missing. And I think it got to pointing fingers.
To clarify, you mean not missed doses, but like literally meds that were missing, that were not in the home.
Correct.
Right.
Correct. Where nursing is saying that they don't have it, but pharmacy is saying they put these medications in there. And I think the way that we mitigated that was we started doing a scanning process to confirm that medications were placed in these cart fills, at least to kind of remove that concern that we were not putting medications in the bag from pharmacy end.
Great, we can go to Catherine for your
Yeah, I'll build off of your pain point first, I guess, just because it's kind of similar. It made me chuckle. Mine was, as I was reflecting about it, is I think we've created a lot of complexity in how we've built out some of these workflows and infrastructures. And the reason is we kind of are forced to live in this hybrid world of inpatient and outpatient. Like that example of missing meds. The reason why this is inherently different is we've introduced a more outpatient-based activity of like packaging meds into bags and things like that. And at least in my experience, our EHR isn't built yet to support that in an inpatient way, right? And so, yes, we have some scanning capability, but it's not fully fledged out. And so we've created these risk points that don't otherwise exist in a standard brick and mortar world. So I think to me, my biggest pain point is just all of these kind of complexities and workarounds that we've developed that really lead to inefficiency and risk points in the operation. But for my aha moment, I was doing, I was thinking a lot about this, and I'd like to say it was a little early on. I was doing some early shadowing as I was joining the team, had the opportunity to go in and see the patients' homes. And it kind of like, you know, I knew what home hospital was, I knew what I was getting into, and then actually going in there and seeing that like we're fitting into their lives, like their lives don't stop. We're working amongst their pets, their toddlers, like just the everyday stuff we have in our homes. And it's not like a hospital grade environment. And so that to me really drove home the point from a quality lens. It can be difficult to fit the nuances of home hospital into inpatient pharmacy workflow. I think we've really kind of showcased that today. But if our goal really is to provide the same level of care, if not better care, I think our pharmacy services really need to rise to the challenge and prioritize solutions for things like compounding. How do we support self-administration in a safe way? How do we find those effective storage solutions that fit into their home? We know for a fact home hospital helps our patients, so we need to be mindful to not let pharmacy issues be a barrier to the accessing home hospital. It really kind of drove me to find some of these solutions and find them from like a quality perspective. So I was happy to get a chance to actually see that and have that aha moment.
I love that insight. Thank you, Catherine. We'll go over to Maggie.
Yeah, I think it's easier to start with a pain point too, because I think some of your aha moments develop from your pain points, right? So it is, we like to say we're taking care of the patient at the same as if they're in the brick and mortar hospital, but it's impossible to do that from a med management operational standpoint. To Catherine's point, like in the hospital, we scan the med at every single point from the time it comes in the door to the time it goes into a patient's mouth. We do not have that line of sight on a med from the point it comes in to the point of the patient mouth. Once it leaves the hospital pharmacy or the pharmacy at this point, it sort of goes into this black hole. And I think that makes inpatient pharmacy really nervous because we've got this, you know, such a level of control in the hospital. We worked years to get that for safety reasons. And so that is a big pain point. And we don't have automation. And so right now in a hospital, a pharmacist verifies an order, 90+% of that goes right to a Pyxis or Omnicell. We never touch it. We refill those devices, but we're sort of going back in time to manual dispensing. And now, we didn't have to touch 90% of those doses. They were available right next to the patient on that floor. Now we have to touch every dose that goes to a patient. And that is a lot of time and effort. But it's important. And so coming up with some sort of automation was our aha moment in Eau Claire, but it took a lot of work to get there. We've gained insight into the home. We've got that sort of ongoing inventory. The meds get scanned into that device, everything coming out of it we can see. And so that's been big for us, as well as just pharmacy engagement. This is a new model. It's really exciting. And us as a profession, or even as professionals, don't get to be a part of this a lot. And so us as a profession to rise above, think out of the box, and not try to fit in the box of brick and mortar. But what does home hospital look like? What can we take the best from every single pharmacy practice? How can we mold those together and create home hospital? Because it's such a beneficial model for the patient. Kayla, you're up.
Yes, thank you guys. So I think from a pain point, it's been really great for our program to have a dedicated pharmacist, just because like everyone has said, there's nuanced workflows for hospital care at home that are very different than the inpatient workflow, and it just needs to happen that way because of the inherent logistical challenges with the patient not being in the brick and mortar. So when you have like the dedicated clinical pharmacist, things tend to run like very smoothly during the day, but then potentially on the overnights or the weekends when you don't have dedicated staff, things can start to fall through a little bit because it's not workflow that the inpatient pharmacy is constantly doing 24/7. And so I think challenges arise when you're trying to think of new and innovative ways to make something work for hospital care at home from a pharmacy perspective. How do you make it work where you're not deviating too much from inpatient workflow that like people just can't keep it together? Okay, what do I do for the brick and mortar versus what do I do for hospital care at home, and then cause risks to happen where it's going to be pharmacy's fault for an error occurring. And I think from the beginning, I kind of had a big aha moment with hospital care at home in that I started my career as a clinical pharmacist where I rounded with the team during the day, and that's when I would catch like a lot of errors or make recommendations to the team. But with hospital care at home, when we're transferring a patient from the brick and mortar to their home, we have pre-transport huddles, and that's an opportunity where the provider gets together, the pharmacist gets together, and the nurse gets together, and we communicate about this patient. We learn, what is this patient here for? We ensure their orders are correct, any recommendations are provided, dosing is correct. And so it's a really proactive way of catching anything before that patient's transferred home. And then it's also been like a great opportunity for the clinical pharmacist to communicate to the inpatient pharmacy, hey, this patient's going to transfer at 8 p.m. I'm not going to be here, but here's like some key things to watch out for when these orders come through the queue. And it's really helped to make the process, at least in the evening with that handoff, a lot easier and less failure.
Great, thank you so much. We are nearing the end of our time. We have, I think, almost 30 questions in the Q&A. We're not obviously going to get to all of them, but I do encourage people to take this conversation over to the users group discussion forum, Basecamp, which you can sign up for through the users group website. And I'll maybe just pull one, I think, simple question. If one of our panelists can answer, how do you handle med waste in the home? What's the process? Someone wants to take that quick one.
I can do it. So medications are brought back to our brick and mortar sites. Each brick and mortar site has kind of like a home hospital, little mini command center that is a clinical space and is serviced by your environmental service colleagues, and so we do medication waste streams there. The one nuance I would say that's specific to home hospital is those medications that are due to be wasted are packaged in the same kind of tamper evident bag to prevent any kind of questions about where it might have gone. And so it all just comes back and then it's processed the same way that it would be in the home. We don't waste anything in the patient's own trash at the moment. And then for controlled substances, we use non-retrievable waste containers, and those can go in patient's trash after the fact.
And we've got, we do waste in the home with containers in the home that meds get thrown into, and controlled substances also go into like the drug buster, the one of those types of products. So we don't bring anything back to campus.
Okay, so two alternative working solutions. Thanks, guys. So we're at time. So I want to thank the panel. You guys have been amazing, so illuminating. I'm going to turn it back over to John to close us out.
Thank you, Pam, and thank you all the panelists. It's been a really rich and informative discussion. Just a reminder that the Hospital at Home Users Group webinar series is available on our website at AHCaH.org. There will be the slides and the recording from this session posted. For more information, you can take a look at our website, and again, please take a look at the Technical Assistance Center at the link noted there. It's a featured resource, as well as many other resources, not only on the ambulatory model described in a webinar in December, but also on pharmacy and other related operational questions as well. We also encourage folks to join us on the Hospital Home Users Group Basecamp discussion. If your question was not answered today and would like some input on that question, please make sure to post that to the Users Group Basecamp. And finally, just a thank you to the American Academy of Home Care Medicine, our partner, and of course our funder, our generous funder, the John A. Hartford Foundation, who makes the Users Group and this webinar series possible. Thank you, and we look forward to seeing you next time.